When the holidays start to feel a bit repetitive, reach for a Sprite Winter Spiced Cranberry and put your twist on tradition. A bold cranberry and winter spice flavor fusion, Sprite Winter Spiced Cranberry is a refreshing way to shake things up this sipping season. And only for a limited time. Sprite. Obey your thirst.
This episode is brought to you by Indeed. You're ready to move your business forward, but first, you need to find the right team. Start your search with Indeed Sponsored Jobs. It can help you reach qualified candidates fast, ensuring your listing is the first one they see. According to Indeed data, sponsored jobs are 90% more likely to report a hire than non-sponsored jobs. See the results for yourself. Get a $75 sponsored job credit at Indeed.com/podcast. Terms and conditions apply.
Hi, and welcome to the MedPrep to Go USMLE Step 2 podcast. I'm Dr. Raj, board certified in pulmonary, critical care, sleep medicine, and I'm the Associate Program Director of the Internal Medicine Residency. So proud of that. And MedPrep to Go, our mission is to improve medical student wellness and reduce educational debt by providing a high-quality USMLE question bank online and in audio format. By making medical education material available to study on the go, we strive to give you time back in your day to focus on your health and well-being. And today, we are going to do 3 questions from gastroenterology, GI. I am super pumped on that. So let's go for it. So, first question is going to be, this is a 64-year-old man presents to the emergency department following a week of worsening confusion and abdominal pain. He reports a month of worsening fatigue and malaise, but has no other symptoms. Past medical history includes hypertension, gout, and frequent presentations to the emergency department with alcohol toxicity, although he denies recreational drug use. His temperature is currently 100 degrees Fahrenheit. Heart rate is 104 beats per minute. Remaining vital signs are within normal limits. On exam, his Glasgow Coma Scale is 14. Just to break it down, the eyes are 4, the voice was 4, the motor is 6. He appears extremely jaundiced. Abdominal exam reveals distension with generalized centerness, evidence of free fluid. I'm assuming that's in the peritoneal cavity, and hepatomegaly. Given the most likely diagnosis, which of the following findings would suggest impending life-threatening cerebral complications? Oh boy. So when I think of this individual, what jumps out at me is that, you got altered mental status, you got jaundice, you definitely have, some ascites. So, and this alcohol use, why not think about, cirrhosis, liver failure? That's definitely going to be going there. But the question is talking about impending life-threatening cerebral. What's going on up here? So what are the choices? Number 1, respiratory crackles. Not even though if I don't know the answer, I'm going to go with no for respiratory crackles. If you have cirrhosis, you could be in a fluid overload state in the sense that you don't have any oncotic pressure because the liver makes all the proteins. You could have pleural effusions. That could be secondary from translocation from the peritoneal fluid going up into the pleural space, but that wouldn't, tell me you have cerebral complications. So I'm going to go no with that. Elevated PT, which is the prothrombin, choice B. That sounds like not the right answer. If you have cirrhosis, the liver makes all the clotting factors except factor 8, my little pearl for everyone. Who makes that is the endothelial cells of the vessels. But just because you have an elevated prothrombin doesn't mean you're going to have cerebral complications. So that sounds like the wrong answer. Hyperammonemia, choice C. No, I mean, I wouldn't say, I would expect it because people who are cirrhotic, I'm assuming this patient is cirrhotic or has liver problems. You're definitely prone to things like hepatic encephalopathy, which is associated with elevated ammonia. But of course, board pearl, that you don't need to have elevated ammonia to have hepatic encephalopathy. But I wouldn't expect elevated ammonia to give me life-threatening complications. That sounds weird. D, hypotension. Well, kind of a really general answer. Let me ask you this, team. In someone who is a cirrhotic, regardless of etiology, what does the blood pressure tend to be? On the higher side or the lower side? Yeah, you folks are awesome. It's going to be low. So do you mean symptomatic hypotension, or do you mean just having low blood pressure to begin with? Is that going to give me a cerebral complication, life-threatening? Probably not. Then I see this irregular breathing, and what exactly do you mean by irregular breathing? I would kind of like to describe it a little bit better, but if you're really going to bully me in a corner, you know what I mean? It almost seems that the writer of this question probably wants us to think about E, because usually when you have an irregular breathing pattern, something might be going on in the CNS itself, in the brain itself. I don't know, things associated with irregular breathing patterns. Could be things, individuals who have like brain herniation or, certain types of infarction that can happen there. So because it's really focused on cerebral complication of the things that were in the choices, I would pick E, and let's see what the right answer is. Yeah. All right. Cool. I got it right. It's irregular breathing. So it says the most likely diagnosis is acute liver failure since this patient has a strong history of alcohol abuse. We mentioned that in the vignette. The patient's jaundice, confused. Okay. A complication of acute liver failure is cerebral edema, which, if left untreated, may result in increased intracranial pressure and eventually brainstem herniation. And they mentioned about this Cushing's triad. Now, one thing that would have been pretty awesome is if they gave the patient the full triad. This patient is tacky, not Brady, and I don't see a blood pressure that makes me feel that this individual has hypertension, but you definitely get irregular breathing. In fact, when I think of irregular breathing with the Cushing's triad, it'd be more of a Sheen-Stokes respiration. I know anytime you say Sheen-Stokes, you think about, heart failure patients, that crescendo, decrescendo, but all right, I'll give you that. Choice A is wrong because coarse crackles may be heard in aspiration pneumonia. And I said hepatic hydrothorax, which is kind of like you could have, pleural fusions from the ascites. There are a lot of reasons, but not associated with, life-threatening cerebral complications. B, elevated PT is incorrect. Not associated with cerebral complications. And because, as I mentioned earlier, liver makes all the clotting factors except factor 8. Hyperammonia is incorrect. Why do patients with cirrhosis get elevated ammonia levels? Is because they can't do the urea cycle, which is otherwise known as the orthodine cycle. And if you can't do that, you're not making ammonia, so it kind of builds up in the body. Cool. And the last is choice D, hypotension is incorrect. Patient in the vignette's not hypotensive, but if the patient developed a shock state, it could definitely develop hypotension. If it was bleeding from variceal bleed per se, that you'd be worried about that in patients. But really, the key learning point is the acute liver failure may result in cerebral edema, which can cause increased intracranial pressure and can lead to brainstem herniation. And part of the Cushing's triad, which is classically hypertension, bradycardia, does include irregular breathing. So in irregular breathing, would be associated with impending brainstem herniation? All right, kind of a cool question. A lot of other things we got a chance to discuss. Let's do another one together. This is a 48-year-old woman presents to the emergency department complaining of occasional sharp epigastric pain for the past month in an episode of hematemesis this past week. The patient reports 6 months ago having a similar pain and received a 4-week course of omeprazole, esmoeprazole, brand name Nexium, which relieved her discomfort. So that's a PPI. She reports feeling nauseated this past week and has noted, quote, coffee ground and, quote, emesis mixed with food content and saliva when she vomited. She denies fever, chills, chest pain, palpitations, cough, wheezing, hematuria, hematochezia, and melena. She denies being on any other medications, including non-steroidal anti-inflammatory drugs. She recently immigrated from Cambodia. Vital signs and are blood pressure is 118/63, heart rate of 98, respiratory rate is 20, DO2 stats 96% on room air, and she is afebrile. On physical exam, her conjunctiva is somewhat pale, and the remainder of the examination is unremarkable. Labs, her WBC count is 13, hemoglobin of 10.8, MCV of 77, platelets are normal at 210,000. BUN is elevated at 38, and the creatinine is 1.2. Patient undergoes an EGD, esophageal gastroenteroscopy, or esophageal gastroduodenoscopy. I love just calling it an EGD, which shows a non-bleeding gastric ulcer without visible vessels, mild gastritis, and a hiatal hernia. Her gastric ulcer biopsy is set for culture and pathology with results pending. CLO testing, which stands for Campylobacter-like organism, performed on her biopsy specimen during her EGD is positive. She is currently receiving intravenous pantoprazole, brand name Protonix, twice daily, and some IV fluids. Which of the following is the most appropriate therapy given her results of the CLO test? All right, what are the choices here? So I'll tell you this much. Anytime they found an ulcer, and this is a gastric ulcer, so a couple key things. When we talk about peptic ulcer disease, this is going to be when we talk about ulcers either in the stomach or the duodenum. And, I don't want anyone to ever get an ulcer in the GI tract, but, if you're going to get one, I prefer duodenum than stomach because stomach ulcers, gastric ulcers are associated with malignancy and they probably need a follow-up there. So it's in the stomach. And anytime you see an ulcer in the stomach, the question is why? And what are some common causes of ulcers? So, of course, non-steroidal goes on there. H. pylori goes on there. Crohn's disease goes on there. And of course, once every 1,000 years, you'll see Zollinger-Ellison syndrome, which is, having a gastronoma. And yeah, I feel like you got to work it up. And anytime they say that they did CLO testing, it's positive. We do CLO testing when we suspect what? H. pylori. So I guess the question should read, which of the following is the most appropriate therapy, assuming she's H. pylori positive? So should we consult nephro for the renal failure? Where did that come from? I think it's because the BUN is 38 and the creatinine is 1.2. I mean, the elevated BUN could be secondary to bleed and upper GI bleed. Maybe the patient's very dehydrated. It's that, 20-to-1 ratio. But I don't think the next step for this patient's going to be consult nephro for acute renal failure. So I'm going to go no on A. B, start octreotide drip. Well, they scoped, they did an EGD. They didn't see anything that indicated varices. And octreotide is the drug of choice for if you have a variceal bleed. So I'm not going to pick B. Start an oral PPI, some clarithromycin and amoxicillin. Now we're talking the treatment for H. pylori. So I kind of like that. D, switch pantoprazole intravenously twice a day to famotidine intravenously twice a day. which is an H2 blocker. But if we're treating H. pylori, I definitely want to stick with the PPI, especially because there's an ulcer there to begin with. I want to go PPI. So D sounds like a bad idea. Give 2 units of packed RBCs. Hemoglobin is 10.8. She's stable. I just feel, no, I'm not going to transfuse this. I hate memorizing numbers, but, wearing my critical care hat, I usually get more excited about treating hemoglobin when it's lower than 7, but more importantly, in what clinical setting. So I don't think it's wrong to do a follow-up, H&H, hemoglobin hematocrit. But I don't think the next important thing in this question is to transfuse at this time. So I'm going to go with C, and let's see what the right answer is here. I have to click view answer. It's C, yay. So a lot of what we talked about is on here. C, CLO stands for Campylobacter-like organism, also known as a rapid urease test. This is a diagnostic test used to detect H. pylori by finding the presence of urease, an enzyme that is produced by H. pylori. Also, considering this patient's background and clinical presentation, H. pylori infection is high on the differential. Triple therapy, including clarithromycin, amoxicillin, or metronidazole, plus a proton pump inhibitor for 14 days is a standard therapy regimen. In regions where clarithromycin resistance is greater than or is less than 15%, and in patients with no prior history of macrolide exposure. So if you do worry about clarithromycin resistance, so if you're in an area where it's greater than 15%, you could do quadruple drug therapy, which can be used sometimes. And in this case, we don't need to worry about it, so you can do triple drug therapy. Choice A is wrong, consulting nephro for what we talked about. This is not acute renal failure. The elevated BUN likely from an upper GI bleed. Choice B, octreotide. We talked about this already. This is not a variceal bleed. Choice D is wrong, switching from a PPI to an H2 blockers. H2 blockers are inferior to PPIs in management of upper GI bleeds, especially secondary to peptic ulcer disease. And choice E is wrong. Patient's stable hemoglobin is above 7. So that would be wrong. So what's the key learning point here? A proton pump inhibitor, clarithromycin, and amoxicillin compose the standard triple drug therapy for H. pylori treatment. And to do a little add-on to that, I also would say after therapy is complete, we do encourage follow-up testing for eradication, which can be done through stool testing or a urease breath test. Cool. I think I gave way too many pearls for that one. I really enjoyed that question.
In Walmart's Nouville, time was ticking away. Only a few nights left till the big holiday. But last-minute gifters had no need to worry. Walmart Express Delivery got their gifts in a hurry. From Nintendo to Nespresso and Lego flowers, they could check off their lists in as fast as an hour. All of Nouville, East, West, South, and North, could order gifts up until 5 p.m. on December 24th. So this holiday, just do as the Who's do. With gift delivery this fast, they all gasped. From Walmart? Who knew? Subject to availability, terms and fees apply.
Oh, Hilton stay. Your beds are soft and cozy. No lumpy couch, no stiff futon, no shower line at crack of dawn. Oh, Hilton stay, a holiday you're saving.
When you want holiday comfort you can count on, it matters where you stay. This season, enjoy spacious, comfortable rooms and friendly service when you book with Hilton instead. Hilton for the stay.
Let's do the last one in this block. I think I'm talking way too much today. 57-year-old man presents to the physician with halitosis. Ooh, smelly breath. Regurgitation of undigested food, progressive difficulty swallowing, and occasional gurgling noise in the throat for the past 4 months. This can't be good. He has not experienced odonophagia, pain on swallowing, nausea, vomiting, heartburn, or weight loss. He has a history of gastroesophageal reflux disease, which is well controlled with a proton pump inhibitor. And he was evaluated with an endoscopy, which was unremarkable 2 years ago. He does not smoke cigarettes or drink alcohol. Physical exam is unremarkable. Which of the following is the next best step in the evaluation of this patient? So a couple things. So what do you think is going on here, everyone? Well, we got this 57-year-old gentleman, and I hear halitosis, regurgitation of undigested food, difficulty swallowing, gurgling noise in the throat. I mean, this is screaming at diverticulum. This is screaming at Zankner's diverticulum, which is, high up in the esophagus. I think the one thing going against it is, 57 is pretty young. I hate to say it. Usually I see it in older patients, not saying it can happen, but usually I see it in older patients. Why did they put no cigarettes or drinking alcohols to say, well, when you think of dysphagia and you drink and smoke, you always worry about, cancer, esophageal cancers. And what esophageal cancer is highly associated with drinking and smoking? That would be squamous cell carcinoma. So it's kind of telling you it's not going to be that. So which of the following is the next best step in the evaluation? Let's see. Choice A, ambulatory esophageal pH monitoring. It's going to be the wrong answer, in my opinion. Why? When do we do that? When you think about GERDs. Now, does every patient with GERDs need to get esophageal pH monitoring? The answer is no. You definitely can treat empirically with PPIs and do lifestyle modifications and reevaluate. But yeah, I mean, pH monitoring is, probably what I consider one of the gold standards in making the diagnosis. And to throw out a little extra pearl in there, you may want to do pH monitoring with an impedance probe. So you can do pH probe and impedance probe, which is basically the same probe, but does two things. And not only does the impedance help you make the diagnosis of GERDs, it also could evaluate NERD, non-erosive reflux disease. And if that's negative, it also will help you eventually make the diagnosis of functional heartburn. But regardless, A is wrong. Barium esophagography, I want to say yes, but it's really imaging what's going on in the upper. So maybe a modified barium swallow would be better. But I do like the word barium esophagography, but I think I'll get something modified, maybe doing it in real, meaning modified what they do it with fluoroscopy while they're eating. But I do like a barium. So far, that's the best answer. B, barium esophagography. C, esophageal manometry. The answer is no. This is not a spastic disorder. It's not achalasia. This patient does not have scleroderma. I don't think manometry is going to be a good answer in this case. D, no diagnostic testing. I definitely feel we need to help this poor guy. So D is the wrong answer. And repeat, the last endoscopy was 2 years ago. And if someone has a diverticulum, like a Zankner's diverticulum, I don't think you'd want to throw the scope in there right away. It could cause, problems, God forbid, perforation. So the one that jumps to me as the right answer is going to be C. No, B. B as in boy, barium esophagography. Let's see what the right answer is. All right. So we are correct. So this is going to be a pharyngeoesophageal diverticulum, also known as Zankner's diverticulum. This type of diverticulum is typically, presents with some dysphagia, regurgitation of undigested food, noisy swallowing, halitosis, and it can be visualized on the barium esophagography. All right, good. Choice A was wrong. As I mentioned previously, choice A is used in the evaluation of GERD. Choice C is wrong because we usually do esophageal manometry for motility evaluations, such as achalasia. D, you definitely want to work this patient up. You just can't say no testing is warranted. And E, repeat the EGD, doing the EGD first wouldn't be the next best step. It's very definitely appropriate to do some kind of barium study first. And because it's in the upper airway, upper part of the esophagus, thinking about doing a modified barium swallow that's kind of done under fluoroscopy where you can do real-time imaging while they're swallowing could be reasonable too. But I do like the barium. I wouldn't do EGD first. So the key learning point is best initial diagnostic test for a Zankner's diverticulum is a barium esophagraphy, including a modified barium esophagraphy. And those are our 3 questions for today. If you haven't noticed, I really enjoyed just talking about. I hope you enjoyed that. And if you want to learn more about me, Dr. Raj, check me out on all social media platforms. Check out my book series, which is published by Elsevier, which is the Morning Report Beyond the Pearls series. And and check out my podcast. That would be great. And I hope you enjoyed this, and I'll see you next time.